Okay, so I introduce myself in the meanwhile.
Yes, please.
I'm the head of the pediatric palliative care team at the Children's Hospital in Zurich since 2008. We are a rather large team looking at different children of all diagnostic groups, and the smallest group has become the oncology group. Um, so mostly we work with children with neurological conditions, as everybody in palliative care knows that, and this is really the other way around, as it is common in the adult part of palliative care. I developed this tool within my master's studies in Cardiff, with the idea to develop an instrument that helps to educate people and to get aware how to, can we now show the, right, how to get started. As pediatric palliative care as well as advanced care planning is not really, obvious to everybody. So the points I want to discuss with you is when is the right time to start palliative care in children suffering from cancer. I want to briefly tell you about the development of the scale, how it is used in Switzerland. It is already used rather often internationally, and what are the next steps. Next. So when is the point to start? We all know the saying, it's not the time yet, but the child suffers from the second, third relapse of cancer. Treatment is experimental since months, and many of you know the high intensity end of life care, which does not mean that we really care about end of life issues and quality of life, but that we provide intravenously chemotherapy less than 14 days before death. And this has become more often in pediatrics compared to adults. And I think this is really worrisome, and we need to think about that. Then the child is an inpatient since weeks. We all know this from our children. The family is falling apart and is suffering. Everyday life is a thing of the past. So again, advanced care planning has not taken place. And sometimes, particularly in oncology, from my point of view and from my experience, we are called when the child is dying. Next. So how can we foresee what will happen? And this is a little bit about prognostication. Next. It's not about weather forecasts, but it's about, and it's not only about survival in palliative care. It's about foresight, knowledge, and expertise. This very well fits to the presentation of Monica we already heard. The preparation of a child, of the family, communication, and clinical decision making. So formulating what are our treatment goals. And this this has been, no, one before, sorry. This has been really very nicely worked out by Paul Clare from Australia in this rather old but still very important paper on prognostication. And we as doctors are not really good at predicting the course of a disease, even if this is in oncology much easier than in children suffering from neurological or cardiological diseases. Next. So when we talk about when is the right time, we need to have a balance between the benefit of a treatment and the burden of a treatment. And the burden of the treatment means that there are side effects and that there may be a lot of limitations in everyday life when the child is, for example, in hospital. Next. So often, particularly in oncology, we need to ask ourselves, in whose interest are we starting the next chemotherapy? When I talk to doctors, they tell me, oh, it's the parents. But when I ask, and you? There is not a clear answer. Next. So when the burden is higher than the benefit, then we are on the wrong way. Next. And I like very much this sculpture of Käthe Kollwitz in Berlin, the suffering, the really suffering of a mother. Next. So the pediatric palliative screening scale had, as I already mentioned, the aims to identify children and families with palliative care needs. And it's not about the diagnosis, it's about the needs. At a stage where palliative care can have an impact on the child's quality of life. And this is for sure not during the last days of life. It is not restricted to a specific patient group or diagnostic group. And coming from oncology, it was very important to me to tell people it's not only about oncology. Another aim is to increase the awareness of palliative care needs in healthcare professionals. So this has an educational aspect. And for me, it's very important that this tool is used by the caring teams and not by the families. One of important findings during the development, and I will come to that in more detail, was that life expectancy probably plays only a minor role. And this tool, which I show to you, is not usable and not helpful in children below 1 year of life, of age, particularly in the newborn group. Next. So the journey of the tool. I wanted to make it simple. And I think Virginia Apgar, with her Apgar score, is a very good model for that. As well as next, the Glasgow Coma Scale, which is also simple, not primarily developed for children, but adapted for children. These two models were in my mind when I started to develop the Papa Scale. Next. And to briefly start, there are instruments for adults, and for sure, when we develop something for children, we always look in the adult world, as Monica also showed with advanced care planning. So in the adult world for tools, you find a lot of tools in oncology, and all these tools are, as often palliative care as well, focused on end-of-life aspects. And this tool from Italy, from Maltoni et al., focused on clinical prediction of survival, first point, Karnofsky index, which we all know well, anorexia, dyspnea, total blood cell count, and the lymphocyte percentage. Next. There is another tool from the UK, and they included not only medical, clinical aspects, but really the aspect of the total pain idea, of the more complex ideas that there are also psychosocial needs and possible also existential matters, not only symptoms which are important to assess needs for palliative care, and in this case, again, terminal care. Next. Again, another tool particularly used in oncology. And finally, next, a tool which is used for all kind of patients groups, again, in an adult way, for nephrology, cardiology, pneumology, the SPICT instrument. Next. So the tool was developed with a model of an instrument, with expert interviews, developing version 2 of the instrument, then focus groups, confirming what was found in phase 1 and then phase 3 with case vignettes leading to version 4. And next, currently we also started to validate the tool within the SPHERA study, a prospective study performed in Switzerland. Next. So I want to briefly show you the instrument covering 5 domains. First domain is the trajectory of the disease and impact on daily activities, which is a really good domain, particularly in oncology patients, where we can see the decline of the course of the disease. Second, expected outcome of current treatment directed at the disease and burden of treatment, symptom and problem burden, preferences of patients, family, and healthcare professionals, and at the last point, estimated life expectancy. And as I already mentioned, this tool is only used for children above 1 year of age, and below you see the 2 publications on the tool until now. Next, I will lead you briefly through the domains. The first domain is covering the trajectory. So we might have a stable course of the disease or a slow deterioration, unstable, and a significant deterioration of the child. And another aspect is hospital admissions with more than 3 during the last 3 months, unplanned, not the current planned submissions, for example, for chemotherapy. And this has been validated by Füdner et al. Several years ago. The second domain, next, is about the expected outcome. No, sorry, one back. Expected outcome of treatment directed at the disease and burden of treatment. This is again rather simple for oncology. The treatment might still be curative. The treatment might control the disease and prolongs life with good quality of life, does not cure, but control and has still an effect on quality of life. Or the last point, nothing of all does happen with the started treatment, which is our experience in daily work. And then the burden of treatment, there might be a low burden or a very high burden. And concerning the scores, you see it's not linear, but there is a step to the 4th point where I think things are really crashing down, and this is also true for domain 1. Next. Domain 3 is covering symptoms and problem burden. How intensive are the symptoms and how controllable are they? So it's not a question about number of symptoms, but controllability. And then a more difficult aspect is the psychological distress of patient related to symptoms, which might be difficult to assess, but more easy in children with cancer. And the psychological distress of parents or the whole family. In a former version, I also had siblings within there, but this was difficult to assess. Therefore, it's more summarized with parents and family. And again, you see absent to significant. Next. Domain 4 covers preferences and needs of patients or parents that they ask for a palliative care support or preference of the healthcare professionals. And it's either way, if the patient parents wish to be supported or nothing, it's not counted twice, or the healthcare professionals. Next. And the last domain is, as mentioned, the estimated life expectancy. Is it about several years, and then it's a score of 0, or is it about days to weeks? Then it's the score of 3. And if it's weeks to month, then the question, the alternative question may be, would you be surprised if this child would suddenly die in 6 months' time? And then you reach to a score between 0 to 35. Next. And the score, this is important, and I think this is the same thing with the advanced care planning. It's not just jumping into a family, but preparing a family and slowly starting the palliative care. Next. So the next validation, as mentioned, was prepared in the SPHERE study, and the SPHERE study is a study which started in 2019 and was closed in 2023. We are still working on the analysis and publication of data. And one of the works was to analyze the reliability of the single domains and the score and the single items. And we have seen that there's a very good inter-rater agreement. And we checked that in Zurich also with a specialist and a non-specialist of palliative care. So I think this is rather well used. There have been some exceptions, for example, item 2.2, so the burden of treatment, this is difficult to define. And surprisingly, the surprise question, question 5.2, was not with a very good reliability. And following that, there was also a convergent validity with other parameters we were evaluating in the Fraser study. So particularly the total score of parents' quality of life, and there was a negative correlation. So if the score was low of the Papa scale, the parents' quality of life was high and the other way around. And there was also a concurrent validity assessed between the items we took from the patient's charts concerning symptoms, and this was well correlated or moderately to good correlated between item 3.1 and 3.2, so concerning the symptoms. Next. So the current shortcomings of the Papa scale are that when patients are becoming palliative during a hospital stay, this is difficult. However, this seldomly happens in oncology. Then second, the estimated burden of treatment and the psychological distress is difficult to estimate, particularly in patients which are on ICU or with neurological impairments. And the item 2.2, treatment side effects, are probably difficult to define. And again, in my opinion, this has not come out yet. The weighing of domain 4 and 5 are rather high and should be adapted. Next. So the use of the Papa scale in Switzerland is the University Hospital in Zurich, and there we use it also for the baseline assessment, which is necessary for the complex coding for the DRG, and often we also use it when we discuss patients within the team and other teams. In St. Gallen, it's also used for, it's published on the website in a modified way, and there also parents can check their needs. And as mentioned, it was used in the prospective Sphere study. And I will only quickly go through the next few slides. It is internationally used in all the countries listed on the right side. It has been translated in Italian. Next. It has been translated in Chinese, and there they have also seen on a more longer course that the Papa score was also showing when needs were staying as such as before during a long term. And in Germany, it was tested with outpatients for mobile care teams, and they have seen that there's a good correlation when the density of home visits is increasing. Next. Next. And this is an article which gets an overview of all different tools which are existing. It's also translated in Portuguese. And next. So all the languages are listed here. Next. Comparable instruments are the PETCOM scale, and next, the Italian people have developed the accept PET pale, and there's an overview of all different instruments existing for assessment and also for outcome, published in the Children. And again, which I find important, there's one paper on phase of illness, and we used that in addition to the score also for the Fraser study, distinguishing between stable, unstable, and deteriorating disease condition or phase of illness. Next. So next steps will be that we finalize the validation within the Fraser study, and we will develop also a scale for neonates and infants. Next. And I think the conclusion is that prospective cohort studies are needed to really evaluate the use of defined criteria and establish evidence-based pediatric palliative care referral practices. And then I thank you for listening, and sorry that I had technical problems.
Thank you so much, Eva, for this insight in the PAPA scale and a clear overview of, well, I guess how we can use it and what it stands for. I see a hand already from Francesca. Did you have a question?
Yeah, hi. Thank you very much, Eva. It was very nice to hear it directly from you explained. That makes a big difference. We use this tool indeed in Minds in our psychosocial group because sometimes we have discussion to define when the patient is, so I work in a pediatric oncology, sorry, when the patient can be officially defined as palliative. And indeed, you pointed already out something that we also struggle with, and that's the definition or the judgment of the burden. So as it's still from our perspective, even though you obviously try to scale the perception of the child, it's still our observation. And this is for us the main point. So I would be very interested in hearing what was because you already said that this is being a challenge, this point. Yeah. What was the observed challenges?
Yeah, I think as you said, this is really it's not objective. It's always coming from the child, and as everybody knows, also with quality of life and estimating symptoms, external people, parents, as well as healthcare professionals are evaluating symptoms more severely than the child itself. And this is also true for young adults. I just care for a young adult of 19 years old with a cancer disease who always tries to tell me that he is doing well, and everybody sees that he is not. Therefore, this will be difficult.
Thank you, Francesca, for your question. Is there anyone else who would like to make use of this opportunity to ask Eva a question about the tool or the use, background? I think I don't see any hands. Okay. Well, thank you very much, Eva, for taking the time to be here and give us your insights. And then we will go on to the next speaker, who is Lorna Fraser. She is a professor at King's College in London, professor of palliative care and child health. I'm not sure if I see her yet, but maybe Lorna, you can.
I'm here, don't worry.
Oh, there you are. So many people on the shortly introduce yourself and please take the floor.
Sure, thank you very much. I'm just panicking that I'm going to be able to share my screen or not after Eva's challenges. So let me, can somebody let me know if you're seeing just, you can see my slides. Excellent, yeah. Thank you. So yes, my name's Lorna Fraser. I'm a paediatrician by background, but I'm a full-time academic, stroke don't have a proper job, as my mother would say. I'm Professor of Palliative Care and Child Health at King's College London, and also a National Institute for Health Research Professor, and I lead a portfolio of studies in children's palliative care. Rather unusually this morning, I'm not presenting on my own work. I'm here to present on the Children's Palliative Care Outcome Scale, which is led by Professor Richard Harding, and I'm part of the team, but Richard is the chief investigator. And this is a programme of work that's been funded by the European Research Council, and probably an excellent example of where paediatric palliative care has been able to learn from the high quality science that has been done in our adult colleagues. So outcome measures assess the change in health or well-being of a patient or child or their family that has occurred due to an intervention for health and social care professionals. And ideally, these are reported by the children themselves. But we know Eva's already mentioned when we're looking at the whole patient group cared for by who require paediatric palliative care services, many of them are young and therefore getting responses may be tricky, but also many of them have complex neurological conditions and significant developmental delay, which means that sometimes, unfortunately, we have to go with proxy report by parent or carer. For most of children with cancer, you're not in that position, and we very much advocate for children reporting on outcome measures themselves where they are, able to do so. And collecting patient-reported outcomes has several applications. I work in a clinical academic environment, and every Wednesday morning I walk past our adult multidisciplinary team who have on the screen the adult IPOS scores of the patients and how they've changed over time. So they're using these outcome measures in everyday clinical practice. But we can also be using them to assess the quality of care, and we can use them for commissioning or funding decisions, and also patients and families can use them themselves to see change over time. And in adult practice, it's been shown to improve service quality, promote person-centred care, lead to better identification of symptom recognition, also increase referrals. Outcome measures are slightly different than the PAPAS tool, but there is some overlap. And importantly, lead to better quality of life for patients. And I've been working in this field for, about 15 years, and I think developing a valid and reliable outcome measure for paediatric palliative care has been a topic that has been raised in that whole time period. And it's through the tenacity and determination of Richard to get funding to develop this tool using robust scientific methods that mean that we're almost at the point that we can be starting to use this. So the first piece of work done around the development of the Children's Palliative Care Outcome Scale was undertaken by Lucy Coombs, a clinical nurse specialist who has also done her PhD as part of CPAWS. And at that point, this was published in 2016, there was no ideal outcome measure which could be used across a whole population of children with palliative care needs. And that's very much due to the heterogeneity of the underlying conditions that the children may have that Eva's already mentioned. There are some specific outcome measures. There are some for children with cancer, for example. There's some for other population groups. But at that point, there was no holistic measure of assessing health-related quality of life that could be used for all children and young people with palliative care needs. So the aim of the CPAWS study was to develop a family and child-centred outcome measure for children with life-limiting and life-threatening conditions and their families, and also to evaluate the psychometric properties. High-quality science is really important when we're developing these types of measures. So it was a large multi-phase mixed method study, and I'm going to go through each of the phases here in following slides, but we followed the Cosman and Rock guidance on how to develop outcome measures. So the pre-development work, I remember this event very well. I was not working at King's at the time, and there was a group of 35 paediatric palliative care people who gave Richard Harding a very hard time about being a predominantly adult researcher and academic, and what did he know about children's palliative care. And thankfully he stayed with us. We gave him some really helpful tips that really I think, helped develop the CPAWS programme. But really, we were highlighting some of the challenges around how diverse and heterogeneous this population was, but also how things like play and social interactions were really important for children, education, but also for our young people, thinking about sex and intimacy was also something that was really important. So the first phase of the development work was a qualitative interview study. We wanted to identify the priorities for outcomes of care for the population. The team conducted 106 interviews with 26 children and young people, ranging from children aged 5 to age 17, an excellent example of inclusive research and giving children the opportunity to tell us what they think, as well as parents and carers, siblings, and commission funders and health and social care professionals. The QR codes link to all of these open access papers if you want to see them all. And what did we see there? So we used the kind of 4 domains of palliative care: the physical, psycho-emotional, social, practical, spiritual, and existential. And you can see symptoms, as you would expect, were important, but as were emotions, memory making, friendships, advanced care planning, as we've already heard from Monica, as well as cultural beliefs, uncertainty of the future, and living a full life. And the other new kind of topic that came up was this normality concept. And this was pre-COVID, and when we first started doing this, but not knowing any different for some of our children and young people who'd had a life-limiting condition since birth. They didn't know any different. But for children, particularly the population you're interested in, what a new normal would be, or striving to retrieve to normality that they knew before they were diagnosed with cancer. Hannah Scott, one of our other PhD students, published on the impact of COVID, in particular from the qualitative interviews that were done during that time. Then we went on to undertake a Delphi survey to obtain consensus on what outcomes were important. And we had 4 rounds of a Delphi. We started off with 82, and for any of you who's tried to do a Delphi, it is a dwindling return, and we had 28 completing the last survey. But you can see that there was consensus in these top 10 outcomes, but also really importantly that these outcomes spread across the 4 domains of palliative care. So we do have psychosocial and spiritual items within there. And again, the paper is available if you would like to read more. We also wanted to understand what was important on a tool that we wanted children and young people to be able to complete themselves. So Lucy Coombs undertook a systematic review on recall period, response scale format, mode of administration, across all kind of child health. What did we understand? And there was 8 key recommendations made here. Really importantly, that we should be undertaking cognitive interviews and psychometric testing when we're developing tools. For younger children, sometimes a dichotomous format is what's appropriate, but those older ones can understand a 3 or a 5-point response format. Again, recall period should be short, so especially for the younger ones, we shouldn't be expecting them to remember any more than 48 hours ago. If possible, children don't often want to fill in bits of paper. They want to use an app or a tablet or something, so a computerized version where possible. And it was quite clear that for those under age 5, proxy measures should be being used, and that reliable data was tricky. And I know that will vary. You will all tell me you have fantastic 4-year-olds who may be able to, but as a general recommendation, they should be a bit interesting. Children are not going to fill in things that don't look interesting and exciting. But you should, very importantly, be analysing and reporting in developmentally appropriate age bands. And that's really important for the broad population of children with palliative care needs. Then we held an item generation meeting to develop the prototype, and we had 22 participants that you can see there. And we ended up with 5 different versions of the measure. Now, that was the minimum number we felt would enable us to accurately be able to record and report on outcome measures. So we had 2 parent proxy versions, one for those under 2 or those whose developmentally would be of that age. We had a parent report for those aged over 2, and Eva's already alluded to the fact that the PAPAS tool wasn't eligible for that. There's something different about that very young age group, and particularly the under 1s. But then for the children and young people, we had 3 different versions. And although they're labelled with approximate, these are developmental ages rather than necessarily chronological ages. And we worked with our children and young people's advisory group to decide how we would label them. And we didn't want to label them with just ages, as for older children who might need to use one design for younger children. We didn't want that to be something that would put them off. So the children came up with planets. I wanted animals, but the children came up with planets. So we have Mercury, Saturn, and Neptune. In our work that we've done developing this scale in Uganda, the children have chosen birds. So African birds are the different versions in their CPAWs. So these are the items, the domains and the questions. These aren't the actual questions here, but you can see again covering all the 4 domains. And there are some questions on the child report. We only ask about the children's versions. In the parent report, we ask about the items for the child and the items for the parent or carer themselves. As I've already said, validation is really, really important. So we started off undertaking cognitive interviews, and here we wanted to assess the comprehensibility, comprehensiveness and acceptability with children and young people with life-limiting and life-threatening conditions and their parent care and carers. So did they understand what we were asking them to do, and would they fill this tool in? So we had 3 rounds and conducted 40 interviews. So you take the tool, we ask them to complete it and ask them questions as we go along. And then we revise the tool and we take a different set of parents and children to check the revised tool. What was really important and came out of this was that a couple of things. One was making sure that we could be inclusive of children who were non-verbal and who could be supported in participating with their parent to complete this tool. But really importantly, from an ethical point of view, the parents were clear that some of these questions were at times distressing, but that they also understood but that to them meant we were asking the right questions. Because if we weren't asking questions that they might find upsetting, we weren't really getting to what was important to them or important to their child. So they really wanted those questions to be answered and asked, sorry. So the final version are labelled there. So we have the 2 parent versions and the 3 children's young people's versions, and you can see within the children's version in the younger age group, we're only asking them to think about what happened yesterday, and we're giving them 3-point responses. For the slightly older children or developmentally older children, we're asking them about recall of the past week, but in Saturn we're asking them for a 3-point format. In Neptune, we're asking them for a 5-point format. So there are some differences between these tools, and we use emojis rather than alongside words so that it's slightly more interesting. Again, you can see the full paper if you would like to read that on the QR code there. And the next stage was a psychometric evaluation. So trying to understand, is this tool valid, reliable, and responsive to change? Now, in terms of validity, we wanted to understand whether this instrument measures the construct it's intended to measure. From reliability, we wanted to understand the degree to which the measurement is free from measurement error. So if those whose condition has not changed over time, does the measure show that their condition hasn't changed over time? And then responsiveness to change. So we want to also be able to measure change over time. Now we have finished data collection, but we're still at the point of undertaking the analysis for the psychometric evaluation. So I can't give you the results from that. And I would also ask that, I don't know if anybody tweets anymore, but if you do, please don't tweet these couple of slides. So the team worked endlessly with a large number. I think we had nearly 80 recruiting sites across the United Kingdom, and we've had more than 500 people complete the CPAWS validation study, including more than 100 children and nearly 350 parents and carers. And you can see that in the child report, we have more in the older age group. That's what we would expect. It's easier to recruit. But even in the younger version, we do have 27 participants. And if you look at the age range, you can see we are capturing some of the older children who may have some significant developmental delay, but we're still able to participate by using the tool that had been designed for the younger children. You can also see the split between children who had cancer and who had other conditions. From the parent point of view, we had nearly 200 completing the younger parent version and 150 completing the older parent version. So we have a good amount of data to be able to assess the psychometric properties that we mentioned. Some of the feedback that we've got from parents and children during this validation study have been really reassuring and have reinforced the importance of what we've been trying to do. So for the first one there, I'm grateful I participated in the study. It helped me assess my psychological mental health as a carer and parent. It helped me fill in the gaps that I didn't care about myself and how to fill in the gaps to be a good carer in terms of my health. It also helped me assess the impact of my child's condition on the family and how to make it much easier, better and enjoyable. Thank you so much for this survey. And the parent on the bottom left, just reinforcing what I'd said earlier, this questionnaire was difficult to answer the first time as I got upset, but I understand this is research and you need the information. And the kids' feedback was great, obviously shorter, but it's nice to be asked and feel important. I helped from my dad, but I understood the questions and I liked the emojis. I found the questionnaire easy to answer. It was good because the questions were good. It was good to think about my condition. I liked the smiley faces. It was just more fun. The children and the parents really valued the opportunity to be able to participate both in the research, but also to be thinking about their own health condition or the health condition of their child and the impact on themselves. Those of you that have worked at all in research will understand that it's all very well developing new ideas, new tools, writing academic papers, but one of the biggest challenges is how you implement that in everyday clinical practice. And we had Hannah Scott, another PhD student who's now completed, looking at the implementation of the CPAWS and really thinking more broadly to start with, and undertook a systematic review about how to identify and synthesize the evidence of what works in terms of getting person-centered outcome measures into healthcare practice and paediatrics. And she found some facilitators and barriers, the importance of the education and training of staff on how to use the measure was really important, but also why it was important to use the measure. You know, what benefit would that have to themselves, and more importantly, to the children and families. There were some logistic and resource barriers. Undertaking research, and certainly in the NHS in the UK at the moment is tricky. We also need to have a real plan. You can't just hand a tool to a clinical team and expect everybody to be using it in the same way. You need a comprehensive plan, and it needs to be agreed on by everybody that's having to participate. Apologies, I hope none of you are hearing my dog who's squeaking a very noisy toy in the background. And having the role of champions, having people who really believe, are very passionate about the use of outcome measures in clinical teams is really, really helpful. And the barriers, if teams didn't understand why this was important in terms of care and outcomes, and particularly if they were thinking of this more as a research study, this was much more difficult to undertake. And lack of resources. We know that's a challenge, but I think we can overcome that. So there was the second piece of work that Hannah did, looking at a reanalysis of the qualitative data that I showed earlier, around anticipated benefits, risks and barriers around implementing person-centred outcomes for children with life-limiting, life-threatening conditions. And really importantly, from her recommendation, we must involve children and families in the development of these outcome measures. If we don't, we'll be measuring what matters to us, not measuring what's important to children and families. But if we want professionals to use these tools, they also have to be involved. So really getting buy-in is so important. And if you think of the pre-development work that Richard and colleagues did at getting buy-in from the paediatric palliative care community, meant that when we were looking for research sites for this, we had people desperate to come and work with us, really keen to undertake and help to develop this. We have to be really clear to families as to why using outcome measures are important, what they are and why they're important. And what the children, what came out from work from the children was they want the professionals that they know to be helping them with this. They don't want it just to be somebody that they haven't met previously. You can read the other recommendations there. I'm not going to read them out in detail, but also you can read the paper if that's of interest. It was interesting to see Eva's slide about international use. I don't think when Richard started this work, he expected this to be such a widespread programme of work. And it's really important to think about where this actually originally developed. Was the Julia Downing and colleagues from the International Children's Palliative Care Network and colleagues from Yves Damazango and co from APCA developed the original Children's Palliative Care Outcome Scale in Africa. Now, it is a slightly different tool because the population who require paediatric palliative care in low and middle income countries is quite different than the population who require palliative care in the UK, but that's where this started many years ago. Richard's also led studies in Turkey and Jordan with children with cancer, refugee children with cancer. We've got data collection ongoing at the moment with colleagues in Australasia. And we've also got quite a number of PhD students and postgrads who are adapting and cognitively testing, translating in modified versions of CPAWS across a number of countries within Asia. And we have plans at present for Italian adaptation and also further adaptation in the Middle East. So a huge programme of work. So conclusion. So I think the outcome measure from paediatric palliative care has been developed and its psychometric properties are being evaluated. I believe it's going to be some of the actual findings from the psychometrics are going to be presented at the European Association for Palliative Care Congress in Helsinki in May for anyone that is going. It is the first patient-centred outcome measure designed for this population and really reflects the priorities and the needs and what matters to children and families in the UK, certainly. And our next steps are really how to get this tool into routine clinical practice to facilitate and assess and monitor key outcomes. Because if we've got it working in routine clinical practice, we can then use it for research purposes as well. And just a huge thank you to the huge number of organisations that you can see here who have contributed either as co-investigators, part of the research team, or really importantly recruiting children and families. And obviously my biggest thanks goes to the children and families who have participated in this study. Thank you very much, and I will